Thanks so much, Andy. Yeah, this is near and dear to my heart. This is EMcrit old school style because early on, yeah, the clinical stuff needed to be talked about. There was not a lot of talk about resuscitation specifically in the emergency department, but what was never talked about was the cognitive psych side of chaotic situations in our specialty in resuscitation. What was born was the mind of the resuscitationist, or MOTR. And there's been a host of episodes on EMcrit on this topic. I'm just going to deal with three issues that keep recurring on the EMcrit Mind of the Resuscitationist series. And so, number one is that amateurs talk strategy, experts talk logistics. This was a quote from Napoleon, and this has been the bedrock of actually managing military operations. Is strategy is a high level discussion, but making it happen is all logistics, and logistics are what really matter. So how does that apply to resuscitation? You could have all the strategies in the world you could talk about at M&M conferences, but saying it versus actually making it happen, that gulf is what I've concentrated on so much on EMcrit, and how to actually take new clinical strategies and actually make them happen at the bedside. And what it comes down to is, as a resuscitation doctor, you need to know how every single item in your emergency department works, how every single task gets done. Now, I know there's a bunch of docs out there who feel that there are doc issues and nursing issues, and that doesn't work. If you're going to be a master resuscitationist, you need to know how every job done in your emergency department is done so that there are no weak links. So that if you are giving a massive transfusion and the nurse does not remember how to use the level one, you could take over, that you could troubleshoot it. That at my old shop, oftentimes we were so strapped for nursing that when a patient needed to be put on a norepi drip, it would take a while to get a nurse to do it. That wasn't acceptable. So things like push dose pressors came. But then I learned how to use the pumps myself. When we were told that we're not allowed to do arterial lines because the nurses don't know how to set up the A-line setups, I went up to the ICU and was taught by the ICU nurses how to set up an A-line. And then I said, it's okay. We'll do it ourselves. And then after we were doing it ourselves for a year, the nurses came back to us and said, can you teach us how to set up A-lines? And then they took that over. Logistical knowledge is the essence of a good resuscitation doctor. If you don't know how to make a high dose insulin protocol actually happen, and you haven't worked out the logistics of that with your pharmacy and with your nursing staff, and the high doses of insulin totally different than they would ever use in a DKA patient, you're going to be screwed when you have a calcium channel blocker overdose come in. If you don't remember the logistics of setting up a transvenous pacemaker or Blakemore, it's never going to happen the once a year you actually do those things for the pacemaker, and the once every 10 years for the Blakemore. So logistical knowledge is everything. Everything needs to be taken down to a mental simulation of how you're actually going to make it happen at the bedside in your own unit. And if you're not thinking that way, you're going to flail when a really sick patient comes in. All right. Second one, slow is smooth, smooth is fast. This is so paradigmatic across the entire EMcrit site. And it doesn't really make sense to people, and they don't believe me, that the way to do critical procedures is as slow as humanly possible. And the example, the story, the anecdote I always give to try to explain this is, every Friday, my wife and I, we go out to lunch, and it always works out because she takes Fridays off and my shifts are from 4 to midnight. So we always have that time. It's like one time in a week with just the two of us, and we go out to lunch. But I usually have to go to the hospital afterwards, so we take separate cars. And so the place is about 10, 15 minutes away, and I gun it in my stupid, ridiculous sports car for everything I have, as if it's like an Indy 500 race. And I am hitting every curve with that perfect line, and I am hitting every yellow light. And she drives a Prius, and she takes her time and looks at the scenery, and she'll probably live years more than I do as a result. And me gunning it and hitting every light and her taking her time gets me there on average 15 seconds before her. But if I get into a crash because of the dumbass way I'm driving, it's going to take a lot longer for me to get there if I get there at all. And that's what it is when you are starting that critical central line in the patient who has no other access and you need it. Yeah, sure, you could rush and you might get there a millisecond quicker than if you did it. And if you botch it up because you were going so quickly, then you added minutes and potentially will never get it. So be as slow as humanly possible, and it will not add any time, but the potential of you getting it on the first try is infinitely increased. Same thing for something like intubation, where instead of going in and making it a unified motion, Rich Levitan talks about, George Kovacs talks about staying incremental. Instead of making it as quick as possible and finding that glottis, where it might work once in a while, but oftentimes going quickly will ruin you. Instead, go as slow as possible and actually stop yourself for each point. Okay, I've gone in an inch and now I'm going to slowly work my way down the tongue. Okay, I visualize epiglottis. I'm now going to push on the thyroid to open up the vallecula. Okay, now I'm advancing in, and stay slow, because slow is smooth and smooth is fast. But sometimes fast is fast. And what I mean by this is you go as slow as humanly possible when you're actually doing a procedure, but you need to learn to be as quick as possible for the setup, for getting things all arranged so that you could start a procedure. And I see residents for patients who have a blood pressure of 60/40 in the course of a trauma, and I say, get in chest tubes or getting finger thoracostomies, and they're opening up the tray and they're laying everything out and they're getting fully sterile, which is great, but it'll be 7 minutes before they touch lung. And that's when you need to be fast, is you got to go slow when doing a procedure, and you have to learn, you have to train yourself to go as fast as possible for setting up a procedure, knowing where every single item is, knowing how to orient it so that it's on your right hand so you don't have to reach across yourself, knowing the additional steps that have to be done by other people in the room. And that needs to be mentally simulated to the point where you're incredibly fast. And you're not like, Hicks has this great video loop of the actual path of a trauma resident for doing a cricothyrotomy, going all around the room trying to find the stuff and then positioning himself one place, positioning himself another. That's what needs to be fast, is you need to get to the point where if you have to do a crash procedure, you know exactly where every single item is, how you're going to set it up to maximize getting into the procedure itself, and then you slow down entirely. All right, the last thing we'll talk about is proactive versus reactive. And this is the difference between a expert level resuscitation or ICU in the ED and standard ED care, is proactive versus reactive. In emergency medicine, it's a reactive specialty for the most part. We take care of patients when they first come in, and then we stabilize them, and then we leave them alone until they have a perturbation, like their blood pressure drops again. And then we go in and we react to it again. And then we stabilize, we leave, go back in, we react to something again. That's not good critical care. Good critical care, the hallmark of it is its proactivity, meaning people, nurses, docs are checking on the patient before they drop their blood pressure, when they're just showing the initial signs of hemodynamic instability. They fix their vent before the patient has injurious settings. They are constantly looking for the problems before they occur or at the very nascent stages of their evolution, as opposed to reactive stance. That's the difference between aggressive critical care and standard ED practice. When it comes down to many things, nursing is the absolute necessity of good critical care in the ED. It's everything. And you need to allow your nurses to have a staffing ratio for the critically ill patients that matches what they get upstairs, which means maximum a nurse with sick patients has 2 patients. If you're not doing that, then you are not providing acceptable critical care in your ED. You're not providing the care they're going to get when they eventually go upstairs. There should not be a discrepancy in that care. Most of our ED patients probably should be 1-to-1, because when they get to the MICU, that post-arrest patient is going to be maybe 1 patient, 2 nurses, and we have them with 1 nurse for 4 patients. It doesn't work. It's purely reactive stance at that point. You can't be proactive. Same thing for the docs. If you have to worry about your entire waiting room filling up instead of the critical care patient, it's the critical care patient that's going to languish because they're not complaining. They're not on the administrator's radar screen. That is reactive care. We need to be proactive. Next step is always be rounding. That's how you know you're doing good resuscitation is you're always rounding. You saw the patient 20 minutes ago. What should you do next? Go back and see him again. Do board rounds continuously on your sick patients. Check out all their labs, check out their imaging, and then go back and see them again. That's how you know good resuscitation is being done, is you're always rounding. And Haney could tell you, that's the hallmark of a good critical care doc, is you're always rounding. We just finished rounds. What should we do? Let's round again. And my residents get in the mindset of they have their portable computer system, the cows. They're just looping the room continuously, rounding on patients. That's proactive care. And then the last mind shift is you move from problem-based response, which is standard emergency medicine, to systems-based response. So instead of just, okay, the patient has sepsis. Yeah, the patient has sepsis and we'll deal with that, but they also have systems and we're going to keep going through them. Neuro, pulmonary, cardiology, hematology, GI, renal, and we're just going to keep going back and forth and looking at the patient as a systems-based approach. That's the difference between critical care and ED care. So we're always in that mindset. This cognitive stuff, not as sexy, but game-changing when you start approaching how we deal with patients from the mindset of the resuscitationist.